Hi, my name is Connie Kleines and you're watching the video on treatment principles as related to amblyopia. Before we commence discussing the types of treatments that we can prescribe for amblyopia, I want us to consider again how we go about diagnosing the condition. So this video will briefly focus on amblyopia diagnosis, and subsequent videos will discuss how we go about managing the condition. Now you'll recall that amblyopia is a reduction in visual acuity that could be unilateral or bilateral that persists even when you've corrected any refractive error present, and that occurs in the absence of pathology. So you'll see within that definition we have three things. We've got to consider visual acuity, we have to consider refractive error, and we have to consider the presence of pathology in order to conclude whether a patient does or does not have amblyopia. So we need to first take a detailed history to determine if there's anything within that history that might suggest that this reduction in visual acuity is amblyopia or possibly related to some other pathology. Visual acuity is going to be key to the diagnosis of amblyopia. Now, generally we need at least a two-line difference or more between the two eyes to diagnose the patient as having amblyopia. This is in the context, obviously, of having a patient with unilateral amblyopia, which is the majority of your patients. Now, you'll recall that the most accurate test for visual acuity is the logMAR. And so the sooner you can get a child to be assessed on a linear chart, such as the logMAR, the better. This is because Sheridan Gardner singles or singles tests can overestimate the visual acuity and may not find that two-line difference that the linear chart may find. Now, in the absence of being able to do visual acuity, usually because of the age or cooperation of the child, you'll utilise fixation preference as an indicator as to whether there is a difference in VA or not. We'll come back to this in a moment. Okay, you'll do an ocular motility exam. You'll need to assess whether strabismus is present, which may explain amblyopia, and you'll need to have a look at ocular movements and stereoacuity, again, to get a complete picture of the diagnosis in relation to motility and whether this may be related to, or whether this may explain why there is a reduction in visual acuity. We need that slit lamp exam and fundus examination, and this is now required, obviously, to eliminate that there is pathology present that may be related to amblyopia or explains a reduction in visual acuity. Now, don't confuse this with deprivation amblyopia, where obviously there is pathology present that can explain reduction in vision. So if we have a congenital cataract, for instance, the reduction in visual acuity is clearly going to be related to the congenital cataract. However, in that instance, if you were to remove the congenital cataract, amblyopia would persist because there's already been cortical changes related to amblyopia. So in the presence of deprivation amblyopia, you actually have two things occurring in that instance. You have the pathology itself, which is contributing to the reduction in vision, and you have amblyopia, which is the cortical changes. Now, in order to work out what portion of the reduction in vision is related to amblyopia and what proportion is related to the pathology, you'd have to be able to remove the pathology. In some instances, you can do this, like in a congenital cataract, you can remove the congenital cataract, and then you can see that the remaining reduction in visual acuity is related to amblyopia. However, in other instances, like a corneal scar, you may not be able to treat that, in which case there will be a combination of reduction in visual acuity that's related to the scar and a portion that's related to cortical changes known to be amblyopia. Okay, and finally, refraction. Refraction is a key component to the diagnosis of amblyopia. One, if we have an isometropia, that can explain why amblyopia is present. Two, if we have high bilateral hypermetropia, that explains ametropic amblyopia. And three, we know that amblyopia persists after the correction of the refractive error. So we need to correct this refractive error to determine whether amblyopia persists thereafter, or the reduction in visual acuity persists thereafter, which would then make the diagnosis of amblyopia. Now, in terms of managing a patient with amblyopia and monitoring any improvements in relation to the amblyopia, the key test that we'll be doing is the assessment of visual acuity. Whilst we know that amblyopia affects far more than visual acuity, for instance, it affects contrast sensitivity, it affects vernier acuity, hyperacuity, we don't concern ourselves clinically with all the various aspects of visual function. We simply look at visual acuity, high contrast letters, and see whether the patient is improving. However, we will have children that are not going to be cooperative with conventional tests, such as the Longmar or Sheridan-Gardner singles, or even preferential looking cards. There are children which you cannot perform a visual acuity test on because of their cooperation or age. So we need another way in these young children to be able to estimate whether amblyopia is present. And we want to do this because the earlier we begin our treatment of amblyopia, the better our success will be in terms of managing their condition. So in this instance, we use fixation behaviour as the guide as to whether amblyopia may or may not be present. So you'll remember that we've discussed that when there's a manifest strabismus present, we can have a look at whether the deviating eye holds fixation or doesn't hold fixation. If the deviating eye holds fixation, well, there's an indication there that the vision may not be very different. If it doesn't hold fixation, it's likely to be amblyopic. If it struggles to take up fixation, so it's slow to take up fixation or does not take up fixation, then we're looking at a patient with dense amblyopia. Now, what do we do when a patient has straight eyes? So we don't have the benefit of the presence of a manifest strabismus to see whether they prefer fixation with one eye over the other. Well, then we can induce strabismus and see what they do in relation to their fixation. One of these tests is the base-to-base Prism test. And we can see here the base-to-base Prism test being performed, where two prisms are placed base-to-base between your fingers and held before the patient's eyes. Usually you're looking at two 15 diopter prisms, or given that a single lens box doesn't usually have two 15s in there, often you can use a 12 and a 15. So what we have is a straight patient. We place two base-in prisms, induce anisotropia, and then watch to see what the eyes do. If they make a conjugate movement to the right, what we'll see is a left esotropia and a fixation preference for the right eye. Now, you could also perform a cover test at this point and see whether they take up fixation with the left eye and whether it holds fixation or does not, or whether it struggles to take up fixation. The other alternative is that with the prisms on, the patients make a conjugate movement to the left, and we see that we end up with a right esotropia, which means that we have a fixation preference for the left eye. And again, if you wanted to, you could perform a cover test here and see whether this eye, or the right eye, takes up fixation and whether it holds fixation or not. The other alternative is that the patient flips between this position here, where the patient is fixing with the right eye, and then alternates to fixing with their left eye. So there's three possibilities. One, the patient prefers right fixation, which may indicate a reduction in left VA. They prefer left fixation, which indicates there may be right amblyopia. Or they alternate between right and left fixation, which indicates that it's unlikely that they have any amblyopia present. So this is a guide to give you a sense of whether amblyopia may be present and whether you should consider commencing treatment. Another alternative is to use what's called the vertical prism test, which is similar to the base-to-base, but here what you do is usually take a 10 diopter prism put it vertically in front of one eye, induce a vertical strabismus, and similarly to the base to base, you look to see whether there is a fixation preference, whether the patient prefers to fix the right eye, left eye, or whether they're happy to alternate. Again, you can perform a cover test during that assessment to see how the patient takes up fixation and whether they hold fixation. Okay, that brings us to the conclusion of this video. Thank you for watching.